Welcome to this explainer. Today, we're diving into a really fascinating clinical decision summary for cutaneous melanoma. We're looking at modern melanoma care, not just as some isolated one-off event, but as a highly dynamic sequence of linked decisions. Every single step we're going to talk about today is driven purely by clinical evidence. It's literally mapping out a patient's journey from that very first biopsy report all the way to long-term surveillance.
Right off the bat, to establish the sheer authority and depth of the evidence we're unpacking, I have to read you this exact quote directly from our source material. Quote, "The underlying article was written and edited by Dr. Thomas Hocker, a Harvard and Mayo Clinic-trained, triple board-certified dermatologist, Mohs surgeon, and dermatopathologist." End quote. So you know for sure you're getting a highly reliable, coherent map that truly guides clinicians and patients alike.
Okay, let's dive into this. Here is our roadmap for the journey we're about to explore. 1. The pathology starting point. 2. Defining surgical margins. 3. Sentinel node staging decisions. 4. Systematic therapy options. And finally, 5. Advanced care and surveillance.
Section 1. The pathology starting point, where the pathway begins. The foundation of this entire treatment pathway relies heavily on two major prognostic variables: Breslow thickness and ulceration. Now, Breslow thickness is incredibly precise. We are talking about measurements to the nearest 0.1 millimeter, from the top of the granular layer down to the deepest invasive melanoma cell. Then pathologists are looking for true ulceration, which means the loss of the full epidermis along with a host reaction. These two factors are the absolute main drivers. They dictate the primary tumor category and basically tell the medical team exactly which questions they need to answer next.
Once we have those precise measurements, we arrive at the AJCC stage. But here's an absolutely crucial point. Staging describes the extent of the disease. It doesn't just automatically dictate one single universal treatment. You could have two patients with the exact same stage, but they might require completely different interventions. Why? Because you have to factor in their specific anatomy, the presence of genetic mutations, and their own personal health goals. The stage is just the framework, but the individual patient defines the actual action plan.
Section 2. Defining surgical margins, tailoring the local operation. For most invasive primary melanomas, wide local excision is the absolute gold standard. The guidelines for clinical margins are based entirely on the Breslow category. For melanoma in situ, we're looking at a margin of 0.5 centimeter to 1 centimeter. For tumors up to 1 millimeter deep, it's a straight 1 centimeter margin. If the depth is between 1 and 2 millimeters, you need a 1 to 2 centimeter margin. And for anything over 2 millimeters deep, that requires a 2 centimeter margin. Remember, these are clinical surgical margins. The goal isn't just to remove the primary tumor, it's to clear that surrounding microscopic risk field where unseen extensions might be hiding out.
Now, you might intuitively think, hey, when it comes to cancer surgery, wider is always better, right? Well, actually scratch that. Long-term trials for thick tumors prove that doubling a 2 centimeter margin to 4 centimeters didn't improve survival at all. But on the flip side, for complex, poorly defined cases, like a lentigo malignant on the face, standard narrow margins often fail. In those tricky head and neck in situ cases, doctors might need to use Mohs surgery or staged excision to precisely map borders that are completely invisible to the naked eye. Sometimes those borders extend up to 15 millimeters. It's like a giant puzzle. It's all about tailoring the surgery to how that specific tumor behaves biologically.
Section 3. Sentinel node staging decisions. To biopsy or not to biopsy?
So how do doctors decide if checking that first draining lymph node actually adds value to a patient's care plan? They use a very practical, step-by-step threshold framework. Step 1. If you're dealing with an uncomplicated T1A tumor, under 0.8 millimeters thick without ulceration, routine biopsy is generally just omitted. Step 2. For a T1B, or a thin tumor that has adverse features, well then it's time for a really careful discussion between the doctor and patient. And Step 3. For melanomas thicker than 1 millimeter, a sentinel node biopsy is generally offered or strongly discussed because finding something there is highly likely to alter the entire management plan.
But what if that sentinel node actually comes back positive? Well, this area has seen a massive paradigm shift recently, largely thanks to the MSLT2 trial. Historically, a positive node meant immediate completion lymph node dissection, literally removing all the remaining nodes in that basin. But modern evidence showed us something amazing: that larger, aggressive surgery didn't actually improve the 86% melanoma-specific survival rate compared to just actively observing the nodes with frequent clinical exams and ultrasounds.
And this number right here brilliantly illustrates why the clinical guidelines shifted so dramatically. Immediate completion dissection caused lymphedema, which is this incredibly painful chronic swelling in 24.1% of patients. Compare that to an incidence of just 6.3% in patients who only underwent active nodal observation. When survival outcomes are identical, reducing harm by skipping unnecessary surgery is the clear evidence-based winner, for sure.
Section 4. Systemic therapy options: adjuvant, neoadjuvant, and advanced care.
This is where medical oncology joins the sequence, introducing powerful systemic drugs for higher-risk scenarios. Now, when we talk about systemic options for resected high-risk patients, we are looking specifically at stage 2B through stage 4, which is pronounced stage 2B through stage 4. And just a quick aside, you never ever say stage 5 in this context. It just doesn't exist. Now, it is absolutely vital to realize that treatment varies heavily within this range. We're definitely not saying every stage in that range receives the exact same treatment. It's completely individualized, balancing factors like tumor resectability, specific mutations like the BRAF V600 mutation, toxicity risks, and the patient's own quality of life goals.
In some cases, clinicians are literally flipping the script on the treatment sequence through something called neoadjuvant therapy. For selected patients with macroscopic stage 3 disease, giving systemic therapy before surgery offers a massive clinical advantage. The Andina trial proved that giving combination immunotherapy prior to the operation exposes the intact tumor and nodes to the drugs, which produces incredibly strong event-free survival rates. It basically lets the medical team see in real time how the cancer responds while it's still in the body, which perfectly guides their next steps after surgery.
When we look at advanced or unresectable melanoma, the strategy becomes this fascinating balancing act. On one hand, you have immune checkpoint therapy. This offers the incredible possibility of durable, long-term immune control, but it carries a risk of higher, sometimes irreversible toxicity. On the other hand, if a patient has that specific BRAF V600 mutation, they can use BRAF/MEK targeted therapy, which delivers incredibly rapid tumor responses. For the multidisciplinary team, the ultimate goal is finding that absolute perfect balance for the individual patient, maximizing long-term control while effectively managing side effects.
Section 5. Advanced care and surveillance. Life after treatment. Here's a really crucial point. Successfully completing surgery and systemic therapy doesn't mean the clinical pathway is just over. Surveillance is highly strategic. The evidence actually tells us that routine imaging, like CT or PET scans, is not recommended for asymptomatic patients in stages IA through IIA. Doing that just turns low-yield testing into routine anxiety and potential harm. For higher stages, time-limited scans are used strategically. But here's the one non-negotiable rule for absolutely everyone on this pathway. Lifelong professional clinical skin surveillance is required, no exceptions.
Why is lifelong skin surveillance so absolutely critical? Look at the stark reality in this data. Nearly 7%, 6.7% to be exact, based on a large cohort study of melanoma survivors will develop a brand new second primary melanoma within 10 years. Beating that first melanoma doesn't just erase the underlying risk profile of a patient's skin. That makes continuous, expert monitoring a lifelong necessity.
We've seen how every single step in melanoma care, from the tiniest microscopic measurement to complex surgical margins and systemic drug choices, is a linked decision, intricately tailored to the individual. But with medical evidence and therapies rapidly evolving year over year, it leaves us with a compelling thought. As these incredible therapies continue to advance, how will patients and multidisciplinary medical teams continue to navigate these deeply personalized, complex decisions together? It's a real testament to the fact that modern medicine isn't just about the science, it's about the partnership. Thank you so much for joining me on this explainer.